What is a more important indicator of health than how long you can expect to live? In the Twin Cities, a short drive down Highway 94 takes you through communities with up to a 13-year difference in average life expectancy. We're increasingly understanding that these inequities are largely a result of social risk factors, as you heard from Rahul and both commissioners already today. Things like income level, food insecurity, housing instability are really important drivers of health. In fact, we're increasingly understanding that only 10% of health is truly driven by actual medical care. Today, I'm going to argue that in order to achieve health equity, we need payment methods to direct money to providers that serve the populations that need it the most. And I'll make 3 points within that overall thesis. So first, we'll take a look at the distribution of patients across providers. And you'll see that patients with social risk factors are not evenly distributed across providers. They're concentrated in a small number of safety net providers. Patients with Medicaid, for example, which is a program for low-income citizens, are concentrated in a few safety net providers like Hennepin County Medical Center, where I work. At Hennepin County Medical Center, 43% of our patients have Medicaid coverage. On average, in Midwest hospitals, 16% of patients have Medicaid coverage. So with that statistic alone, you can see that there is a concentration of patients in particular providers. Even among the Medicaid population, people with social risk factors are concentrated in safety net providers. So you can see that the rate of homelessness at Hennepin County Medical Center is over twice the rate of homelessness in other IHP participants. The Star Tribune reported earlier this year that Mayo's CEO told employees that the system would give privately insured patients priority when scheduling medical appointments. This put a spotlight on the issue of payer mix and generated a lot of discussion in Minnesota and nationally. Increasingly, the hospitals who can afford it are trying to attract even more commercial patients by offering hotel-like amenities. This is a quiz in the New York Times, which you can take, with a series of photographs of lobbies asking you to indicate whether it's a hotel or a hospital. And if you want the answer, you can see me at the break. I'll tell you about that picture. Medicaid typically covers between 50 and 85% of the total cost of care. The current system of add-on payments does not close that gap. And what this means is that the populations that most need investment are not getting it. Reimbursement for the same work is less, much less for Medicaid. For example, the average reimbursement for colonoscopy in Minnesota is almost 3 times as high for a commercial patient than it is for a Medicaid patient, and that's for the exact same work. Next, I'll argue that providers have an important role in identifying and reducing health disparities. But in order to do this, we have to address the social determinants of health. At HCMC, we've been developing a model of how to address social needs. We believe that first we need to identify the needs, and we're doing that through things like screening for food insecurity in all of our clinics and creating an indicator of homelessness that the commissioner referred to earlier. And then we take 2 paths. The first path on the top is informing clinical care based on those social determinants of health. Homelessness is a health hazard and exposes people to risk of diseases like TB, frostbite, influenza, and it seriously complicates treatment and continuity of care. So by taking this risk factor into account in our clinical treatment, we can do a better job with our patients. The second path on the bottom is to connect people with resources to help address those social determinants. At HCMC, we're doing that in a number of ways, including an electronic referral within our EMR system to Second Harvest to help people get connected with food resources in a more permanent basis. But this work costs money. It costs money to keep people in the hospital when they're medically stable but don't have anywhere to go. It costs money to provide care coordination and social work resources for patients. And it costs money to leverage technology to make those connections. We've started to measure the additional costs we incur in working with patients with social risk factors at HCMC. This is not the gold standard because we really should be doing more, but these costs are often invisible to payers because they're not necessarily reimbursed by our current system. And so we're starting to measure those and share those with payers. So DHS is really taking a leadership role in this concept of enhancing payments to address social risk factors at providers where those patients are seen. In their IHP 2.0 model, there is going to be an enhanced payment for social determinants within the population-based payment. Nationally, other organizations are also calling for enhanced payments for providers that serve vulnerable populations, including the National Academy of Sciences and the National Quality Forum in their recently released Disparities report. You've likely seen this picture before showing equality, which is not necessarily the same as equity. The current state of our healthcare system actually is inequality because we have less investment for the shorter children here who need more, which creates inequities. To achieve health equity, we need to invest more at providers who serve populations with social risk factors instead of less, as we do now. Thank you.